Welcome back to Rural Health and Health Equity, Unit 2 of our 2-unit module. I'm Elizabeth Cartwright, a retired professor in the Department of Anthropology at Idaho State University. I'm a medical anthropologist and I've worked all over the world, but like Diana, I'm also born and bred out here in the western United States, and this is a place I love to be. Today we will share the story of Idaho CommuniVax, a program that was designed to address COVID-19 vaccine access and acceptability in the rural Hispanic communities of southeastern Idaho. Idaho CommuniVax is part of CommuniVax, a national coalition of social scientists, public health experts, and community advocates who seek lasting solutions to a serious problem, health inequity in underserved populations like the Hispanic communities of southeastern Idaho. Our project was funded by Johns Hopkins Center for Health Security, and they receive funding from the Chan Zuckerberg Initiative and the Rockefeller Foundation. We conducted research rooted in Paulo Freire's educational philosophy. It's one of my favorites. This philosophy encourages experiential learning and application of newfound knowledge to real-world problems in real time. Our purpose for conducting the research for Idaho CommuniVax was threefold: raise awareness of, access to, and acceptability of COVID-19 vaccines for the Hispanic population in Southeast Idaho, strengthen national and community local vaccination efforts by creating a strong communication network between our local Idaho communities and decision makers and policymakers, develop sustainable solutions to health inequities that existed long before the pandemic came about. To achieve this, we employed a rapid research as intervention strategy. While we did research, we also implemented interventions that engaged community members as much as possible. As soon as we had new knowledge based on good research, we applied it. The specific area where we employed the RAI approach was in and around the communities of American Falls and Aberdeen, Idaho. These very rural areas with approximately 1,600 square miles of land. These have a population of 16,000, 31% of which is Hispanic, some of whom are undocumented. The top industries in the area include agriculture, agribusiness, food processing, and transportation, and warehousing. Many employees of these businesses are Hispanic. There are a multitude of health disparities in this population. The rural nature of these communities contributes to the fact that they are health professional shortage areas for primary care, dental, and mental health care. Access to care is further limited because 41% of Hispanics ages 19 through 64 in the area are uninsured. In late 2020, Hispanics in Idaho had a 20% higher rate of hospitalization due to COVID-19 complications than should be expected based on the proportion of the population they represented, which is around 12% depending on the numbers used. Our research team for Idaho CommuniVax was strategically convened to address these kinds of disparities. What did that team look like? What did we want from and for the team? We wanted our team to be representative of the communities and to include trusted members of the communities. That's the best way to move the needle on health equity. If our team was representative of the communities, it meant that they might have experienced inequities themselves. So we made sure to pay them well and to build in learning opportunities to help them with professional growth. To meet our team vision, in January 2021, we hired 20 Idaho State University students who were in the health professions and social sciences to work as our research team on the CommuniVax project. Half of these students were Hispanic, bilingual, and lived in American Falls and Aberdeen. We then set about training them to gather the data that we needed to answer the questions we posed by CommuniVax. None of the students had any prior research experience, it should be noted. We did all the team meetings and trainings online via Zoom and the Moodle platform. First, the students completed human subjects training to make sure they knew how to ethically and responsibly conduct interviews. Then we taught them how to do qualitative interviews. This is the first time for many of them, so we practiced with them, they practiced with each other, and finally they were ready to go out and do interviews on their own. By March 2021, they started interviewing people within their family and social bubbles, their mothers, fathers, grandmas, and grandpas, many of whom are agricultural workers in rural southeast Idaho. Others were interviewed too via Zoom so that we maintained COVID-safe practices. We also interviewed white community members residing in these areas. This allowed us to understand what part of people's responses were cultural, ethnic, and what ideas might be shared by the wider community. Between March and May 2021, the Idaho CommuniVax team conducted and analyzed 89 interviews. 41 interviews and 2 focus groups were conducted specifically with members of the Latinx community, and 1 focus group was conducted with public health officials. 32 of the 41 community interviews were conducted in Spanish, and 9 were conducted in English. Our large bilingual team was able to complete enough interviews to make sure we had really good understanding of our research topic. Through conducting focus groups with our team after they were done with the interview process, we were able to capture more in-depth responses to the interviews and to engage in thoughtful reflection on the situation of rural Hispanics in southeast Idaho during the pandemic. And about that research as intervention process and approach, this slide provides an example of how we were able to intervene in real time, even though we were still in the middle of our research process. We intervened by making a simple change in messaging and communication, which built trust in the communities of interest. The Public Health Department was preparing Spanish language flyers, and it became apparent from the interviews we conducted that it would help a lot to clarify on the flyers that no documentation would be needed to receive a vaccine. Many people in the community were concerned about this. They thought proof of U.S. citizenship was required. We were able to get this information on the flyer so quickly because we had bi-monthly meetings with the area's public health director and our vaccination team. Information was shared quickly and responses were made quickly. Our student researchers also attended these meetings and learned about how public health works in rural state. Long-term personal connections between the members of the university team and the public health team facilitated this work immensely. Several students ended up doing internships with the public health office and area clinics because of their work on CommuniVax. New opportunities were there to help them build their careers. What did we learn from this project and all of those interviews and focus groups? We learned 3 critical things. First, we learned that in the Hispanic community, there's a high drive to be acknowledged as being a worthy member of Southeast Idaho society and culture. The way to do that is to work, even in conditions that could lead to COVID exposure and illness. As one respondent said, we were the essential workers of the ranch, and we kept working. We did not stop. Thank God, we did not stop even one day. People were willing to get vaccinated so they could continue working. This changes the dialogue about acceptability and who needs to be the focus of acceptability interviews, because there are others in rural southeastern Idaho that do not, under any circumstances, want to be vaccinated. For future research, we propose asking the following. What can we learn about entrenched cultural forces that stifle acceptance of evidence-based practice around COVID-19? How does trust fit into this equation? Second, we learned from the project that there's a lack of political will and capacity to support public health in Idaho. We need to focus on this if we want to change. Here I provide 3 examples. Right in the middle of the pandemic, May 2020, the state of Idaho stopped funding our public health districts. The portion of the funding that used to come from the state now has to come from counties or other places, and the counties are already contributing to public health program sustainability. Number 2, mask mandates are nearly impossible to implement and enforce because governing bodies are reluctant to support such initiatives. And number 3, vaccination data in Idaho can be unreliable, like a lot of places. The state of Idaho did not start collecting race and ethnicity data until late February of 2021, about the time that vaccines were first being rolled out. That translated into no ethnicity data for 29% of those who had been vaccinated at that time. Without proper capacity and support to collect data in a consistent and reliable way, it is truly difficult to understand the magnitude of health disparities in our state. Third, we learned that engaging students as future providers and professionals has the potential to make long-lasting change when it comes to local knowledge about vaccines and health equity in rural areas. Community-university partnerships that engage students who will be future healthcare and community professionals creates evidence-based communication channels between the students, their families, and their communities. These communication channels will remain long after CommuniVax is gone. This was the greatest project. It brought together students from all over our university. It brought together researchers. It brought together public health people from our community. And, we were integrated into a large national project. So we had the ability to interact and to get ideas and to learn from others across the nation at Johns Hopkins, at many other wonderful research institutions. And it was truly a fabulous project to work on and to be a part of. And Diana and I had a great time doing it with the students. Here's some great references for you. Thank you.